Yes, 1 second. You can start now.
Okay, good morning to everyone and welcome to Monty Art. Today our guest is Dr. Arif Khokhar, who is a great friend of us, both me and Dr. Latif. He's an expert, I have to say now, in this topic that will be optimizing TAVR insights from bench testing together with very good group of friends. He developed and he did so many of these simulations that led also to many publications, right, Arif? And he's really innovating in this field, and we will see how this can optimize the techniques we are performing today and how the future will be thanks to this. Please move forward, Arif.
Great. So thank you, Andrea, and thank you, Prophet Teeb, as well. It's for me a huge pleasure and honor. I've been following the Monty Hart series since throughout my training and a lot, and I've always learned a lot and enjoyed a lot. So it's really nice to be able to come back and maybe give something. So the topic is about bench testing, and I thought I'd start a little bit, but what is bench testing? A lot of people ask sometimes, what do you mean by bench testing? Is this kind of the classical pipettes, beakers, solutions? Are we doing computer simulation? Are we ex vivo? What do we actually mean by bench testing? And I've came across this, which I thought was a really nice article by Alain Cribier, actually describing the development of TAVI. And you can see almost 15, 20 years ago, this is what bench testing was, using equipments and technology to understand how our different valves are made, constructed, and behave under different environments. It's just that now the machines and the technologies that we have are more sophisticated. So we can really look into hemodynamics, durability, the leaflets, look at really close interactions between different frames and valves, and now introduce also patient-specific bench testing that we can do now. And I really encourage anybody interested in the topic of bench testing to look at this editorial by Stephanie Sellers Group and David Mayer, because they really put into perspective, where does bench testing fit into this different ways of we can do, research that we can do, and this sort of hierarchy of research. And in particular, why is bench testing useful or helpful? I think it's really this exact point, because you can perform multiple different tests and do multiple different configurations inside a specific either anatomy or a physiological condition or scenario. So it allows you essentially to do things that you cannot do in vivo. As a simple example, you take the redo-TAV field. You can't, inside of a patient, implant a combination of redo-TAVI, take that out, put another one in, take it out, put another one in. Whereas in bench, you can do that. So I was thinking what topic to discuss how bench testing has contributed to our knowledge, and I thought where better to start than TAVI and young. It's a very important topic, it's a growing topic, and particularly in the US, this is something that's discussed a lot. And when we think about the young population, what are the key things that come to mind? Well, absolutely the importance of optimizing the index valve, the issue of lifetime management, so redo TAVI, valve and valve, which journey to go on, and then all the coronary challenges that we're facing, including coronary access and protection. So these are the three topics I'm going to focus on for this talk as to how bench testing has helped us understand the topic of underexpansion, redo TAV, and then coronary access and coronary protection. So let's get into it. So starting off with underexpansion, well, we know that this is something that applies across the range of different transcatheter valves that we have, whether it's self-expanding, balloon expanding. We know different patterns exist. And really, when we start to look at the leaflets, so these are normal, concentric, well-expanded leaflets designed to meet the size that this nominal valve should be across different valve platforms. When you look just at a glance, you can see how underexpansion is affecting the leaflets. You can see both the way the leaflets open, but also the structure of the leaflets. And if we look in a bit more detail at this, what do we see? Number one, you've clearly got a restriction in the opening of the leaflets as well as the geometric area. You've got impaired coaptation, and that actual central coaptation point, which you'd get from that Mercedes-Benz sign, is shifted off to one side. If you look on the top right panel, you can see sort of at around 6 o'clock, you've got these creases inside of the actual leaflet belly itself, as well as this leaflet pinwheeling. And so this is how really the leaflets can be affected. And the question is, what impact does this have? So here we're going from well expanded to severely underexpanded. And you can see as you have mild degrees of underexpansion, you don't really affect your gradients that much in an ex vivo setting. Predictably, as you start to increase the degree of underexpansion, your gradients do rise. But importantly, you don't quite hit that threshold of that VARC3 technical failure of 20 millimeters of mercury. So what does this mean? I think perhaps one suggestion coming from this is that gradients may not be the marker or the signal that we have under expansion. So you finish a TAVI, no PVL, no gradients, you may still have very significant under expansion. And now we need to understand whether that's relevant. So here you can see we've got a normally expanded valve. You've got nice laminar flow, central jet, your sinuses wash out really well, and you have decreased shear stress upon the leaflets. You compare that with a severely underexpanded valve, and you can see you've got much, much more turbulent flow, a very eccentrically directed jet, less washout, increased shear stress. And we know from prior computational modeling studies, as well as other ex vivo work done with particles and imaging particles, that this can then contribute to increased risk of blood stasis and subsequently thrombosis, which may begin to explain some of the hypotheses we're now seeing in some of the clinical trials with underexpansion. So how to correct it? Well, it starts off with an effective pre-dilatation done at an appropriate size. In the cath lab, you can see we're just rotating to RAO with this balloon expansion. And that's where on the left-hand side in your 3-cusp view, balloon looks well expanded. You switch RAO and you can see you've got an indent in waist. So playing with our C-arm for pre-dilatation. Same principle here with the valve. You've got a nicely expanded, concentric, circular valve. Because it's a circle, no matter which way around you look at it, it will always look the same dimension because it's perfectly well expanded. Keep that same principle in mind. We've now put in here an accurate valve, which is underexpanded, severely underexpanded, but well aligned. If you were to look in this 3-cusp view, you would look into the major axis of the valve, and you can see that the frame looks to be really well expanded. If you then rotate round into the sort of conventional cusp overlap or right-left overlap view, that's where you would see the underexpansion of the frame. So it's having this awareness inside of the cath lab that we need to use our C-arm, number one, to look at this thing from different planes. And number two, we need to understand that the valve that we're implanting, what's the signature that valve will have of underexpansion, because it'll be different for different valves. Then following valve implantation and effective post-dilatation, you can see these are both 25 millimeter accurate valves. On the left-hand side, you're post-dilated with an 18 millimeter balloon. Barely touches the edges, and you have absolutely no effect of the post-dil. You look on the right, you take an appropriately sized balloon. This is a 24 millimeter true balloon, and here you see the valve expands and achieves better expansion of the valve. So you actually correct the underexpansion problem effectively. Just to show that in a different way, looking on the inside, on the left, we've got this underexpansion, small balloon, no impact. Now on the right, you take an appropriate sized balloon, and you can see how you can actually expand the valve. Because this is nitinol technology for self-expanding platforms, it then retains its shape, but you have to give it that push. So to summarize, with underexpansion, we've got different patterns. These patterns affect the leaflet structure and function as well as blood flow patterns. The importance of using that C-arm to help us evaluate it, and then the importance of an effective pre- and post-dilatation. So next topic, redo-TAVR. Redo-TAVR was quite complex when we first started this field. We were trying to understand something which was a little bit difficult using either fluoroscopy, then trying to use CT scans, trying to explain quite complex concepts with diagrams. And really here, I have to say the work from Jonathan Webb's group and Janar and David Mayer and Miriam and colleagues, they have absolutely revolutionized our understanding and contributed so much through the medium of bench testing to our understanding and knowledge of redo-TAV, both in terms of how the frames are, so this issue of neoskirt height, how the frames are modified during redo-TAVI, what happens to the expansion, but also looking at the leaflets and really explaining to us this concept of leaflet pinwheeling. What is it? When does it happen? When does it matter? Quantifying and evaluating leaflet overhang, as well as the opening of the second valve. And there's really a lot of work's been done. They've looked at different combinations of valves, and you can come up with these charts. So in this chart down the, if you like, the x-axis, what you've got is different combinations of redo-TAV with sapiens and evolutes. You look across the column, you've got different heights. And if we just take two examples, so let's just take a 29 sapien and a 34 evolute, implant low, implant high, this is the information that you can get. The neoskirt height, so you know exactly how high your leaflets are pinned up, corresponding to how much leaflet overhang you would get, how much dimensions of your evolute will change, how much the valve is stretched out. And then they've gone on to show that what are the hemodynamic consequences of having all these different implantations at these different heights. Of course, one of the limitations, which is all comes back to bench testing, is that these are new valves with clean leaflets. And that's why I think this was a really interesting study which they performed. So Stephanie Seller's group took these explanted, calcific, degenerated evolute valves, and you can see here really high mean gradients, 50s to 70s, so really, really calcific stenotic valves. And then they did redo-TAVR inside of these valves and then did all those assessments. So you can see that they're basically increasing in size. So we've got 23, 26, 29 to 34. You maintain that leaflet overhang. You get probably high gradients on the small end, which is not to be expected, but your gradients are otherwise okay. And then what's really interesting when you look at the leaflets, you still do have this leaflet overhang, and it's not affecting the gradient so much, but you've got quite a lot of pinwheeling. If you look at the sapien inside, you've got this complete disruption of what should be an ideal Mercedes-Benz sign, and that's what pinwheeling really looks like. And you can begin to see some of the problems that might happen. So look here how these deposits of calcium are protruding through the frame. So this is calcium on the evolute valve, protruding through the frame, impacting the sapien valve. And then it's not a surprise at all that they showed very nicely. So the yellow line is what the sapien should be inflated to, and then the blue line is let's say a deviation from what is optimal. So a lot of underexpansion of our second valve, which is a sapien valve, because the first valve was so calcified and stenotic. So I think we've learned a lot from the work of the group and others about how these valves behave, what happens to the neoskirt, overhang, also evaluating the hemodynamics of these different combinations, and not just with new valves, but now degenerated valves. And again, this underexpansion coming out to be a problem. So moving on now to the coronary challenges and how we can address these and answer these. Well, this we found was quite a difficult topic. You've got so much anatomical variation, so many transcatheter valves, so many different catheters, and we're trying to study something which is quite a dynamic process. You know, you're moving things around. It's not just static images that we really need. And I think this is the biggest challenge with coronary access after TAVI. We are still trying to use the same catheters and the same techniques that were taught to us from about 50 years ago, when we were doing all of this with nothing inside of the aorta. And now we're putting layers upon layers of stent frames, valves, and leaflets, and we still have to try to cannulate. So we took a different approach. What we do is in bench testing, we take real CT scans of patients, create these digital models, and then 3D print a one-to-one life-size anatomical model, which replicates the in vivo sizing, but also we've worked with the materials to replicate the feel of doing these procedures. It's connected to an anatomical pulsatile flow simulator, and then that allows you to put any combination of transcatheter or indeed surgical valves in any combination, alignment, depth, anything that you want to test inside of that patient. Then all the testing is done in a real cath lab under full catheterization laboratory conditions. We've got all conventional tools that you would want to use inside of a cath lab. And then essentially you are just experimenting and trying and evaluating and understanding. This is a little snapshot of how it looks. You've got the X-ray image. You're looking down in the middle to really see what's happening with not only the leaflets and the catheters, and then you're fully basically working inside of the cath lab. So with this, I'd just like to share with you some insights. So, some of the challenges that we face, this is native TAVI. This is a tall frame accurate valve. You can see on the left-hand side, you're coming with your EBU, you're trying to push, but for some reason, everything looks like it should be fine. You've got a well-aligned valve, your depth is okay, but you just keep pushing against something. You may not appreciate that. You look on the inside and you realize you're hitting a commissural post. This is an example now of an evolute valve. You've come down with your EBU, you've pulled your wire back, you're about to make the curve, and you can see for some reason that valve is not going through the cells of the evolute. And you may again not understand because, and this is the fundamental thing, we don't see the leaflets on X-ray, and we don't know where those leaflets are. And you can see on the right-hand sort of screen what's happening. The leaflets are pinned open. Now, this is actually something that's happened to me twice, where during one case was a left main PCI with an evolute using just an EBU, tried to push the EBU down to get a bit more support, and then suddenly the pressure crashed. And you basically pinned open the leaflets and given yourself severe AR. So it's having this awareness of, be aware of what you don't see and what catheter you're using. Moving on to redo-TAVR, well, this is leaflet overhang. This is how leaflet overhang can interact and affect you. You can see on the X-ray that actually the catheter, as it comes down, pull the wire back, you're above the sapien. So it looks like it should be fine, but you're trapped within these overhanging leaflets of the first valve. This is the leaflet neoskirt. You can see, again, those top row, this is a sapien inside of an accurate, that top row of the sapien, we know it's an open cell. It should be easily accessible, and it certainly seems the case on X-ray. But when you look inside, you can see that's what leaflet neoskirt looks like, how it essentially just covers up your top row and you can't access through there. And then this is really the worst case scenario. You've got two misaligned tall frame evolute valves, multiple cells, a dense mesh, posts, high neoskirt. This is why when we talk about putting two tall frame valves together for coronary access, you can see just instantly how it can create a problem. So we've been working to develop some different techniques. These are some new techniques we've been developing with the Accurate platform, both in native TAVI, but also redo-TAVR. And I'll probably just share with you one particular one in the interest of time. So I'll let this video play. This is what would be considered or classified as challenging coronary access. You've got an oversized Judkins left catheter coming down along the inner curve and then entering the sinotubular junction and achieving the cannulation and completely bypassing the valve frame. So all these challenges of coronary access are all located in a central portion where your leaflets are, where the valves are. And if you can just avoid the central portion, use your inner and outer curve, deflect down to the sides, you can achieve the cannulation. Let's look here. This is redo-TAVR. Catheter comes in, you're caught in the leaflet overhang, you're just pulling up, and then you go straight in. And you can see, I'll try and pause it just in time to understand that you avoid completely the central portion. So as this comes down, I'll just pause the X-ray image there. You can see how you're completely free of the middle portion. And this is using an oversized Judkins left, which always raises a lot of eyebrows. So let's try and understand that. Avoiding the central, you want to deflect to the side. So here, same anatomy, same patient, same valve. We've put a Judkins left 4 and a Judkins left 6. Now, in both cases, you achieve the cannulation, but you can just see that with the 4, you are much more central, going through the middle of the valve frame. Therefore, you're much more likely to encounter obstacles and barriers. But with the 6, you're using the gap between the primary and the secondary curve, not for its horizontality. So it's not like, we've got a dilated aorta, so I want to upsize my Judkins left from a 4, 5, or 6, but rather we're using that horizontal distance vertically to try to avoid the middle. And then we've been now, having done a lot of work in an ex vivo bench testing, we're now starting to use this technique in vivo. And again, it seems to work really well. Of course, we need to learn when is the best time to use it. And there's a difference between cannulating and then needing sufficient support for PCI. But this is now the next phase of this work. So take-home messages from coronary access. I mean, being aware of what you don't see on fluoral, having an understanding when it comes to redo-TAVR that your combination will dictate your challenge. Is it leaflets being too high? Is it the frame, cells? And then I think really we have to move towards this idea of developing valve-specific cannulation techniques. Of course, I appreciate that we have so many different valves in the market, so it's impossible. So really we need some systematic principles, let's say, for different valve designs. Next, I want to move on to coronary protection and how bench has helped us here. This is exactly a setup of a redo-TAVR setting with bilateral coronary protection. And this is kind of what we do, where we can create these scenarios and then see what works well and what doesn't work well. I'm pleased to share with you, this has just been accepted this week, actually. So this is hot off the press. We looked at chimney stenting in the setting of redo-TAVR and tried to understand what factors were relevant and when did it work well and when it just did not work well at all, both looking at the actual chimney stents through micro-CT analysis, an IVUS analysis to look at the stent expansion, and also coronary cannulation. And it's probably self-explanatory, but the factors really were the design of your first valve, alignment makes a huge difference, and then of course the implantation depth of your second valve, because you can get this crushing phenomena of your chimney stent. So let me show you this. This is a bad case scenario. So this is a sapien in a high position with a completely misaligned evolute valve. This would be, let's say, the worst case scenario. If you look just in this panel, which is looking sort of through the valve frames on CT at the chimney stent, you can see the stent is completely crushed. So there's going to be absolutely no patency of the stent here. You can see how distorted the stent is in both a vertical plane and also a sort of a horizontal or a lateral plane. And what we try to do is, after we deployed these stents, we then tried to perform an IVUS measurement to look at expansion, eccentricity, ellipticity, everything. But when the stent is crushed, you simply can't get back in and you can't perform the IVUS. So this was just, again, confirmation that it can sometimes go really, really wrong. And we need to understand that if I need to have a coronary protection strategy for my case, well, what variables are relevant? So I've got a misaligned valve. Okay, I want to implant my second valve high. Be careful, chimney may not be the best thing. And this is just showing that. So this is the same scenario. And have a look here at how crushed this stent is, basically trapped between the two different frames of the two valves. And you can see there's no way that you may have some flow, but it's not hard to expect that this would then eventually thrombose and you would get essentially stent failure. So then moving on from chimney, then the next thing is leaflet splitting. So what impact does that have? So here we looked at just balloon in tall frame valves. And of course, leaflet splitting really helps you increase the feasibility of coronary access, which is different to coronary flow, let's say. So coronary obstruction is what we all fear. But if this field is moving towards younger patients, we need to really maintain coronary access for lifelong. So here we found that leaflet splitting does help. And just to show you an example here, so this is sapien inaccurate. You can see there, you've got this curtain again that I showed you, which is covering the open cells of the sapien, and you simply can't get through that valve. If you cut the leaflets, look at the difference here. The catheter is just going to be pulled up, and those previously inaccessible open cells, the catheter just slots in. And that just shows you really nicely how leaflet splitting can really, really help in terms of coronary access and make what was unfeasible feasible again. However, it's not the complete answer, because you can see in this scenario, what we've done is we've actually misaligned the first valve, just to highlight that you may achieve a perfect splay in the leaflets, invested all the time, energy, and effort, and then if your first valve is misaligned, well, it's not going to work, especially if your post is directly in front of your coronary artery. More worryingly, you've invested all the time and effort. You've achieved a beautiful splay, as you can see in this example at 6 o'clock. And then you've gone and a commissural post of your second valve, which in this case happened to be a sapien, ends up directly in front of the splay. Now, you may still be able to preserve flow, but when looking from the perspective of coronary access, you will not get the benefit really of the leaflet splay. So I think really one of the big signals that came through this work that we did was the absolute importance of alignment of both valve 1 and then also valve 2. And we also looked at the impact of balloon-assisted basilica. Does that have a bit of an impact? Can you gain more benefit? This is just showing you the example of sapien and evolute. And you can see, because essentially when you cut the leaflets and you create the splay of the first valve, which in this case was the evolute, you then take your sapien, and particularly if you're going with a high sapien, you're just jailing those leaflets back against the frame, the cage of the evolute. So we found that there wasn't that much to gain, let's say, from balloon-assisted basilica in this bench setting. Fully acknowledge that in real life, leaflets, calcium, it might behave differently, but we didn't see that much of a gain, let's say, from doing a balloon-assisted basilica. So I wanted to share a case study with you. I was actually hoping this case would be done yesterday, but it's been deferred, so actually will be done tomorrow. But I think it brings together a lot of how bench testing can help us, and also a lot of the things that we've learned and we can apply to clinical practice. So very briefly, this is a 77-year-old patient here who has a degenerated accurate neo2. The degeneration is severe aortic regurgitation, heart failure decompensation, and just a few snapshots here. So on the left-hand side, you can see that that upper crown is almost at the upper border, if not just above the left main stem. So if we go by conventional descriptions, the neoskirt plane for this valve is higher than the coronary risk plane. So high risk for coronary obstruction or unfeasible for redo-TAVR. Look at the middle panel. What we see is that gap between the where we expect our sapien to go and the aortic wall, so the valve to STJ or valve to aorta distance, it's about 2 millimeters, maybe 2 to 3 millimeters. And on the right, that's really exemplified in this 3D reconstruction. The sort of light lime green color is the sapien, dark blue is the accurate. You can see you're really, really close. So this is essentially probably unfeasible or very, very borderline for redo-TAVR. So what we did is, and this is some of the work that we're now doing, is you can see on the left, that's what the intact leaflet would look like. In the middle is a basilica splay, and on the right is unicorn. Now, of course, there's been a lot of interest recently in unicorn, and people are starting to do these procedures. And that's an area of now research where we're trying to explore where and when unicorn can add and give you a benefit. And you can see here, just on the still frame, that this is the same scenario. What we've done is we've taken the exact same patient, taken the CT scan, and created this anatomical model. And you can see just in the middle frame how that barrier is created in the sapien open cells, and there's no chance. Contrast that with here, you performed a unicorn inside of this first valve, and then you comfortably get not only flow, of course, but also comfortable coronary access. So the plan then tomorrow is to do the unicorn of the accurate valve, place a sapien, and fingers crossed, we hope everything goes well. So I hope that's given you a little bit of an insight of how bench testing has helped us understand, let's say, gain knowledge, improve some of our practices, but if nothing else, just sometimes given us a visual overview, which helps us understand better what we're doing, particularly when we're working in X-ray in a single plane on 2D, for the topic of underexpansion, redo-TAVR, and some of the coronary challenges. If you're interested, there's a lot more information available on the redo-TAVR app from Vinny Bapat. So we've got a dedicated section for coronary access where you can access some of these videos and learn and watch a lot more. And these are continuously being updated as we learn more and develop more. And finally, I do want to say that, of course, it's an entire team effort, and there's lots and lots of people involved in this. But in particular, the group has been tremendous and has been working really hard to develop a lot of this work and come up with a lot of this research. And also the engineers, I mean, they're fantastic, and it's an amazing collaboration what you can achieve with physicians and engineers working closely together. So big thank you.
Arif, congrats. It was really an impressive talk. You covered everything, and now we finally see what you are doing with all this bench testing when you go with Alessandro, Jonathan, and all the others. So congratulations. It was really inspiring. We have like several questions, and then we'll ask also here all the audience to ask other questions. Maybe I'll start with one. I see you are covering many topics. Maybe let me ask you, how are you using this for in the clinical routine? I see you are planning a case tomorrow of redo-TAVR. So you are, of course, you did a CT. Do you think there is space to do like a virtual simulation of the valve, or what do you think? How do you think we can apply all these concepts in real life?
Yeah, I mean, I think that's a very reasonable question because a lot of people ask. Look, I think overall, virtual simulation is one thing, and then these 3D printed models is another thing. It's labor intensive and resource intensive. So this stuff is expensive. So it's not like this is going to be used or should indeed be used for every single procedure, every single case. But I think cases which are really borderline, or where you're really absolutely not sure, too much blooming artifact on CT, too much doubt, stakes are high, then the technology exists. Technology exists, use it, and it can certainly help. Virtual simulation, I think, can really help you because it just gives you that 3D perspective to understand the geometry a little bit better. And then if there's still doubt, or you want to see how something looks or try it, then I think that's where the bench testing or the 3D printed model can really help. I think is probably the minority use of bench testing, the majority being the ability to evaluate different scenarios in same, anatomical conditions, for example.
Yes, also I was impressed by seeing the Basilica, which didn't achieve such a big split as we imagined based on all the studies we did on your bench test. Did you see any difference, or it was always like this?
Yeah, it depends on the first valve. So actually what I learned was the importance not only of the metal. So is it a full cage or is it a partial cage, let's say, like a split level design, but also these tissues are behaving differently. So depending on, I'm sure, and I don't have this answer, but maybe the engineers can answer better, but all these different leaflets and tissues have probably different tensile strength, the way they're stitched, the way the curve is on the tissue, that even they're behaving differently when you do Basilica or even unicorn. We've been working with unicorn and trying to create let's say, the hole. And the number of balloons you need, the size of the balloons, the type of the balloons is different for different valves. And the one thing that's constant is that these are all brand new valves off the shelf. So you can't say that, oh, maybe the difference is because that one has more calcium, less calcium. Just even brand new valves off the shelf are all behaving differently. So I think there's a lot to learn also with the tissue material type.
Arif, maybe let's do one step back. I see a very interesting question. A user is asking, what's the difference between Basilica and Unicorn? Why will that then work instead of Basilica? Maybe would you like to explain what's the difference and how Unicorn works compared to Basilica?
Yeah, sure. Maybe actually the simplest way would be to explain it like this rather than getting fancy. So let's pretend that this is a leaflet here. I don't know. Can you see that? The sticker note is a
Yes, I
leaflet.
can.
Very simple. Basilica is this. You just make a splice in the leaflet. That's it. You cut through. You can eventually have a look at all the equipment and things we do. But basically, all Basilica does is create this little splay in the leaflet. Now, contrast that with, I'm sure Ollie won't mind me using all his sticky notes here. Contrast that with now unicorn. Here's the leaflet of the unicorn. It's causing the obstruction. What you're essentially doing is you're poking a hole inside of the leaflet like that. And then you're just making that hole bigger, 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 bigger. And then eventually you're coming with your valve and essentially avulsing the leaf. Well, it doesn't break off, but you avulse the leaflet completely. So that's the fundamental principle of how the two are different. The other key thing is that Basilica creates a smaller gap. So if you imagine this little splay that I showed you, it creates a little splay. Why unicorn was then developed? Well, one thing, I think it's maybe procedurally a bit easier. You're not having to snare a wire and then pull up and splice. But the second thing is you would expect, and as we are seeing on bench, you do create a much bigger hole because essentially the entire leaflet is taken out. And so if you're not sure whether Basilica will be effective, coronary is too low, you can't get really down to the base of the leaflet because, you know, a Basilica is a V. So if your coronary is just here, how much benefit will you get? But with a unicorn, you're taking out the complete leaflet and the entire cusp, essentially, of that valve. So I think that's where the two differ and why unicorn was then developed.
Thank you. I think this really explained the difference between the two techniques. I see we have a question from Wakas. Wakas, you would like to?
Hi, good morning. Thank you very much. A very interesting talk. I have a question regarding the coronary access. Like most of these structural patients, some of these patients are going to end up in like some other hospitals where the interventionists are not very familiar with the valve and coronary access. In STEMI situations, do you have any pointers to get an easy access to the coronaries?
Yeah, absolutely. So, you know, it's absolutely impossible to come up with things that are going to be relevant for every single device valve. So we can adopt a systematic approach to coronary access, and this is something that's independent of the type of valve that you have. The very first thing is it depends on the access that you choose. So of course, we all like radial now compared to femoral. We know it's better. But if we have to choose, left radial. And, you know, if it's really a difficult case in the middle of the night and you've got tall frame valve, if you can go safely with an ultrasound, go femoral, because with femoral, you'll have much more support. The curves are much more natural. With left radial being a bit similar to femoral, you can access the inner and outer curves much more easily. So number one is the access side. Number two, maybe in a chronic stable angina, not an acute STEMI setting, if you have time, just evaluate what you have in front of you using the C-arm. Simple principle. Have I got a tall frame valve, a short frame valve? Where do I think the leaflets of this valve might be? I.e., where is my danger zone in terms of my catheters? And number three, this, of course, if you're a non-TAVI operator, might be difficult, but if you are a TAVI operator, is my valve aligned or misaligned? So you're already in your head building a little picture of, okay, what challenges may I face in front of me? Then the third thing, again, if there's time, take a pigtail or you just do a non-selective injection in the cusp that you're targeting. So left cusp or let's say the right cusp in an angle, C-arm angle that isolates that particular coronary. So let's say you're targeting the LAD, you just go to an LAO cranial as you would do for left main stenting, do a non-selective shot. And what does that tell you? That tells you what's the height of my coronary in relation to the valve frame and how much gap do I have? So these three things, simply the access route, the evaluating the frame, and then using contrast, you've not even thought about what catheter to pick. So this applies to all TAVI valves. Then you can go and choose the catheter that you think might be best. Of course, I would generally say use what you're familiar with. That's what we are as interventionists. We're better with whatever we know how to use. But you know, this concept that people talk about in CTO, if one thing doesn't work, quickly switch strategies. Don't insist with one catheter forever and ever and ever with dye, contrast, radiation. Know what your next catheter might be. So let's, for example, say it was an accurate valve and I started with a JL4 and it was difficult and I was struggling. Within a few seconds, I would just switch and upsize. So you just know where you're coming next. And then I think final thing would be have a low threshold for things like 0.14 wire fishing, using a guide extension catheter. So I think these principles are independent of whichever valve you have.
So Arif, let's maybe go a little bit more into the weeds with this because I think it's great for you to share, both of us, but particularly you with the benchtop, to share your experience with people. So like in the US, where most of our fellows and Wakas are going to be working, there's very few accurates. Okay, because it was only in the clinic, it was only in the study, and you know, based on the data of the ID, I'm not even sure this device will get approved. There's a lot of Edwards, but Edwards I don't think is an issue for them. It's like as if there's a surgical valve there, so you're not really gonna have issues in the middle of the night. But it's really the core valves, right? I mean, that's where they're gonna see most of the problems, and so I do worry about, Wakas has a real question. Every couple of months, I get referred a case from upstate New York where they couldn't cannulate a coronary, and they asked me to take over the patient and do the procedure, and that's okay when it's stable. But there's Wakas he's worried. He's going to be. I'm doing a lot where he's going to go work. I've treated a lot of the patients up there, and a lot of them have core valves now. And one of them is going to come in the middle of the night, and they're going to have a STEMI. And poor Wakas now has to get into the coronary. So we have to give him some real practical advice, whether it's a left-sided STEMI or a right-sided STEMI, right? So I like what you said. I think femoral left radial go are best. You should never go right radial for these. I am going to agree with that. I think the other thing with the core valve, depending on the aorta, is to be sure you're inside the valve
Yeah.
and not outside the frame.
Yeah.
And it sounds like crazy, but I've seen people struggling for like 30 minutes and they're outside the frame. So one of the things I do, I like what you said about the pigtail. I'll go with the pigtail sometimes, and then I'll push out a wire from the pigtail. And if the wire crosses the valve and goes into the ventricle, I'm super happy. I leave the wire in the ventricle, and I'll follow that wire then with my catheter, because now I know I'm definitely in the valve. So that's another trick I do. I think Judkins catheters for the left are pretty good. You may not get the support. I learned something new from you today about oversized Judkins, so thank you. I'm going to try that next time. I think EBUs are also fine, but generally you have to size your EBU smaller than you would normally if there was no valve there. So if you know what valve it is, like it's a 23 or 26 core valve, I would generally go with an EBU 3. If you know it's like a 29 or 34, then maybe an EBU 3.5. And tell me if you disagree, because you've done it on the bench. I'm telling you what my clinical experience is. The other thing I like doing, just for the fellows, and I think Arif mentioned it, is like you said, fish for the coronary, which means like get your catheter close and then just try to blindly wire the coronary. Okay, that's like a really important trick. So when I do these, I have two wires usually in my guide catheter. And since you trained at the same place where I trained, you're going to know what I'm about to say. Is I have a coronary wire in, and I have the back of my 035 diagnostic wire in. Okay, and I use the back of the wire to make my guiding catheter into a steerable guiding catheter. So my EBU can open, close, and by doing that, I can then fish with the wire, as you call it, in different cells. I like that too. And then I think what you said is super important for them. Once the wire is in, like I almost always will put a guide catheter extension to go in, and follow with a guide catheter extension. So the left is usually easier than the right. I don't know what you found on the bench, but I definitely, when you look at the clinical data and my own experience, rights can be more difficult. I tend to stick with JRs, or I will try an AR. I rarely use AR in a PCI on the right, but inside a valve, I'll try an AR, or I'll try an AL 0.75 with a short tip. Those are the catheters I've tried clinically and seem to have worked. Any other suggestions, Arif?
I've read and I've seen a couple of people talk about a JR5 or JR6 because you
Yeah.
just have an extra little, tip that just allows you to get through the cell frame.
Cool. That's
Colleague
nice.
there actually mentioned an Ikari. I don't know. I've never
Yeah.
used it. I've never had it in my hands, but they mentioned that sounds like something that might be useful. Completely agree with you. The right is the more difficult one. I think it's because it requires more rotational movements to engage, whereas the left were kind of up and down. So you're just trying to get the right angle. But apart from that, I haven't, the only one caution I would say, which I've seen with ALs a lot on the bench, is they are really pushing on the leaflets, because these leaflets are a lot higher. Let's say the leaflets are stitched lower, node 3, roughly, but where they coapt is a lot higher than maybe what we might appreciate on the fluoro.
Right.
And so I've seen it twice. once with an EBU and once with an AL1 in a real case,
Yeah.
where I'm trying to achieve that more supportive condition, the hemodynamics just crash. In one case,
Right.
we were actually a bit delayed in being aware of that fact.
Yeah.
And then, it was a negative outcome. So I think caution with the AL when you're working in these tall frame valves, or even if you're really pushing your EBU down to
Right.
know if your pressure does drop.
Right.
Apart from that, I think one other thing I would add just to the left is use the C-arm because it can really help you. So isolate the cusp or the area you're targeting. It's a bit hard with the right. You have to go really steep LAO on that, but really target the cusp. And the other thing is sometimes I've seen people using the Sapien. It can help a little bit with the Evolute, a very steep areocranial. Essentially, what you achieve by going very steep areocranial, you get the valve as a sort of almost a short axis. And then if you inject contrast, you can sometimes see that, for example, oh, my catheter is pointing, let's say 10 o'clock, and my coronary is 1 o'clock. And then you just know, oh, okay, because I'm at the right height in terms of the cells, but I just need to go a bit more clockwise, or I need 2 cells more to the right. That
Right.
can sometimes help with this.
Yeah. And so I'm going to add to it. I absolutely agree with you about the AL. That's why I suggest, and I didn't see it used as much in Europe, but in the US, we always keep on the shelf an AL 0.75, which is smaller than the AL1. And
Okay.
so it's like really super useful. I mean, you should look if you have it, because I remember in Italy, we didn't have it. And then you get two. You get the normal one and you get a short tip one even, which can be really useful. So if you ever get a chance to try it on your bench, Ars Medtronic has this AL 0.75. And I agree with you. One of the things I've kept a leaflet open many times, and the one trick is, we sometimes we're manipulating, we see the blood pressure drop, is to just look at your diastolic pressure. So if you because sometimes you think, maybe it's just because I'm against the wall or I'm against something, but if you're seeing your diastolic pressure drop, then that's usually a sign that potentially you're opening a leaflet and you're holding a leaflet open. So, Wakas, did we answer all your questions?
Yes, thank you very much. That was
Okay. All right. So the one other thing I would say to you, Wakas, the last thing I've tried, which is what I've had to do only once or twice, is if I'm doing like a STEMI and I really can't get in, I'll go back to using a diagnostic catheter, like a 5 French diagnostic JL, and just because it's smaller, it will get into the coronary. And once it's in the coronary, then I will put in 2 300 centimeter like coronary guide wires, and I'll pull out that catheter and then go with a guide catheter. So that's something I've rarely had to do, but that's probably the last trick I have up my sleeve that I will try sometimes. I hope that helps you.
Yes, thank you.
I think what this illustrates really nicely is have this list, let's say, the sort of mental checklist of next strategy, next strategy, next strategy, next strategy, because it's independent of the valve that you will use. It's more an in-lab thing. Okay, if this doesn't work, I'll do this, I'll do this, I'll do this.
Right. Absolutely. So I'm sure there are more questions, but I have a couple of questions, and now I'm going to ask you. So let's go back to section 1, right? We were talking about how the valves respond with underexpansion. Okay. So let me ask you this question. We continue to be told by the companies, right, that when they test their valves in accelerated wear testing, okay, they test it in out of round shapes, right? So they put it into an oval shape or an oval structure or an undersized structure, and then they put it on the accelerated wear testing where it opens and closes for 600 million cycles, all right? And we keep hearing from them, okay, but we don't see anything wrong with the valves, even when they're out of round. Yet when I see your pictures, they're dramatic. I mean, I don't want a valve in my patient or in me that looks like those pictures you've shown. And then you see also the data from like Vinny Pappert recently, where they show increased thrombosis in sapien valves that are not fully expanded. So, like, where's the disconnect? I mean, is it just, is it, do we not believe, we can't believe benchtop testing when it's done by industry, or it's just the whole biological process is different?
Yeah, I mean, I think many different ways of answering that. Firstly, I think underexpansion is we're using it now as a binary term, and it's not a binary thing. There are clearly patterns. So you can have something which should be 29 and it becomes 24, but it's still a circle.
Okay.
You can have something which could be, an eccentricity where major minor axis is 1 to 1.5.
Mhm.
or you could have this severe indent. So the images I was showing you was like a real indentation. So for example, a very calcific NCC nodule, which just, is almost like an infold. So I think we have to understand these different patterns of underexpansion. Then also at what level the underexpansion is being applied. So there's a lot of work which people have done looking at evolutes, for example, in bicuspid, where your inflow is really constrained, but then at the level of your leaflets, it becomes much more circular, and you therefore maybe don't impact the leaflet so much. With the sapien, where you would expect all the calcification to be is kind of also where the leaflets are. So maybe that has an impact. So I think maybe by we, I mean the entire community looking at this topic, has maybe used underexpansion in too much of a binary sense, and we have to really tease out to understand. I got interested in it, so I went and read all the ISO documents that they have. Part 1, 2, 3 was a very dry Saturday. But in there, I found one particular table which said that according to ISO standards, ellipticity with underexpansion is 1.2. So let's say 1 to 1.2, they say is okay. Beyond 1.2 is then they would consider to be abnormal. Now, I don't know what's being tested. This is now
Fair
kind of,
enough.
I'm curious
Absolutely. Neither
to
do I.
understand.
Yeah.
And I think, if you were to take, something which is 29 and it achieves 26, you would get pinwheeling, but you would still have symmetricity of your leaflets. Get a big indent, well, that's completely different. And that's going to affect your leaflets differently. And then your blood flow patterns, stasis. So I can't answer your question, if I'm honest, but it's clearly, I think, a lot more nuanced than perhaps we first thought about the issue of underexpansion.
Absolutely, absolutely, and I think that's a great answer. I think there's so many variations we see actually in patients because of the anatomy that are not seen on the bench or completely reproducible when companies do their testing, because they do just probably, like you say, to a certain level of elasticity. So I love the picture of the stenting, the chimney stenting, okay, because it kind of justifies what I force my team to do, and that is unless the patient's left main is occluded, even if it's at risk, okay, to try never to stent from the jail guiding catheter if we have to chimney. So we leave the guiding catheter in, we leave a wire in case anything happens, and then if the patient is not obstructing their left main, even if it looks at risk, we will then cross again, okay, in the center of the valve and through struts, and we'll chimney into the valve. Because of that picture you just showed. That picture has always scared me. We saw it once a few years ago. So I was really happy you showed it. The one thing that worries me, though, is I think we're going to see, unfortunately, more of those because of TAV in TAV.
Yeah.
And I often worry about TAV in TAV, about, the two metal frames, and now you're jailing your guiding catheter between two metal frames. What that's going to look like, it's going to be really ugly. So I'm become more and more fascinated with unicorn.
Yeah.
Okay. We've done lots of basilicas, and into response to someone's question on the chat, whenever we do these procedures in our center, we try and use embolic protection. So we'll use a sentinel device to protect from stroke because we're very concerned about pieces of material embolizing to the brain. And we've done like a lot of basilicas over the years. And despite basilica, we've also had sometimes even left main obstruction despite a basilica. Okay. So I've become interested in unicorn, and I was hoping you could help me with this, and maybe with my thought process because of the bench. So basilica was initially invented for surgical valves. Right. And I remember those pictures from the bench of a surgical leaflet. So you made a little slit like this. That's essentially what you made. But when you push the leaflet out, right, because it can go past the post, it does that.
Yeah.
Right. I don't know if you can see my hands. I'm sorry.
Yeah.
So it kind of opens up and splays more. Okay. And that's part of because there's just the post. There's nothing stopping from the leaflet from splaying, especially if you do like a valve, like a mitral flow, where there's actually nothing, right? You can like really splay it open. When you do TAV in TAV, though, okay, you now have this metal frame that stops the leaflet from splaying, right? So even though you've cut it, it just stays there. It stops. It doesn't splay. And I wonder if that's part of the reason, like even on the bench or what you're seeing, that basilica doesn't work as well for TAV and TAV. And we may have to, for TAV and TAV specifically, do unicorn. Any thoughts?
100% agree. This is exactly what we're looking at right now, because one of my colleagues, Alessandro, who of course some of you know very well, he did this very nice work looking at comparing basilica and, let's say, balloon-assisted basilica with accurate as first valve or evolute as first valve. The principle being that in one case you've got this cage running from all the way from the bottom to the top, and the other one you've got exactly as you say, these kind of open leaflets,
Yeah.
like a surgical valve. And there is a difference because when you push those open leaflets after having made a cut with a sapien, they just splay, they splay out. They have space to create the gap. Whereas when you just essentially you cut the leaflets and you just put a cage against a cage, you're just like jamming the leaflet. So you create a little tiny cut, but not that big as perhaps we've seen actually on the previous, let's say, bench work with surgical. So I completely agree with you. Whereas with unicorn, having done some of these, what's interesting, first of all, the way the leaflets are, the way the leaflet is moving or being avulsed, a little bit alarming, of course, but it stays attached. Haven't seen it dislodge, but of course, these are new valves. But it's completely out the way and it's independent of your first valve design. So independent whether it's a cage, whether it's split level, whether it's open leaflets or closed leaflets. So completely agree with you that I think your unicorn is maybe favorable in an agnostic sense almost. It doesn't matter what your first valve is. With basilica, there's maybe situations where you will get more benefit and others will get less benefit. Simplest example I can think of is if your second valve happens to end up being misaligned, then you don't really pay a penalty with unicorn because
Exactly.
you have so much
You
space.
destroy the leaflet. And also, I think if your first valve is not perfectly aligned
Yeah.
as well, you have more room, right?
Exactly.
So you've encouraged me. I'm going to do my first unicorn next week. And if anything goes badly, I'm going to blame
Let me
you.
know how it goes.
But I'm encouraged because I've been like struggling with this, and when I saw this case that I have to do next week, that basilica is not going to be good enough, and maybe I need to try a unicorn. So I'll do one next week, based on our discussion. I'll let you know how it goes. Let me ask you one other question. The one area though, and I don't know if because all your work has been on actual TAV and TAV mostly. The one area I'm concerned about unicorn is native valves. Right. So like yesterday, me and Andrea did a basilica on a native valve. We do about half our basilicas are actually on native valves, because we'll have these patients, again, small annuli, long leaflets, no sinuses, and the coronary is low. Right. And we don't like, even though we've published so much on chimney stenting, we don't like chimney stenting anymore. So we'll do a basilica to maintain access. But I'm really worried about doing unicorn in a native leaflet because I don't know. I mean, at least when there's a surgical valve or TAVR valve, the frame is going to stop the tear from going too close to the base. It can't go past the frame, right? So it has to tear the leaflet away. Okay. I just don't know when you have a native valve, and I would love if there's any way you guys can prove it on the bench that I'm right, is when you have a native valve, what's stopping that split from going towards the aortic wall,
Yeah.
right? And into the sinus and rupturing the whole sinus.
Yeah. I don't know. The one thing I've seen with the TAVI valves is that your leaflet is always, it's like swinging on one commissure post.
Right.
So when it's been stitched, there's one of them it comes off and the other one so it's always stuck to a commissure
Somewhere. Yeah.
But where would your native be stuck to by
Exactly.
definition? So I have no idea. I mean, yeah, and it also worries me more that that's a scenario I can see a lot more debris flying up.
Okay. Anyway, I'm going to stop asking questions. I'm going to give it back to Andrea. Congratulations on all the work you're doing. I'm very proud of everything you're doing. Keep it up. Okay.
Okay, let's see if we have other questions from the audience. I don't know if Taylor, Matteo, Manaf, do you have any questions?
This is Taylor. I don't have anything specific, but I just want to say that was an excellent talk, very informative. I appreciate it.
Okay. So Arif, I think you really answered all the questions, and it was a really interesting talk. Thank you again for presenting here. Of course, we can get so much information from bench testing. I don't know if all these models can, because they cannot reproduce like the generated leaflets. Do you have any thoughts on that? Can we get there in the future to also simulate how this splitting, let's say unicorn, basilica, or whatever, in which direction is going? What's the risk of, because when we don't know when we inflate the balloon, where the leaflet is going to be destroyed in the case of unicorn. Do you think we can get there with bench test, or is mostly a simulation scenario?
Yeah, I mean, to give you my, like, say, experience of the last 3 to 4 years, I've always said something is impossible, and then the engineers come back with a solution. So I've learned now to not say anything, just tell them that we want to look into this. So can you look into it? And generally speaking, they come up with a solution. So I now humbly would say probably it is possible, and it just needs a bit of, let's say, time, attention, and thought. I have seen examples where you can replicate degenerated calcific leaflets and they move like degenerated leaflets. You get high gradients like degenerated leaflets in a simulation setting. And that was instantly the first thing I was thinking when you were mentioning about doing this in native. So I think so, yes. But it just needs someone to take on the challenge and do it.
Thank you. Hopefully, this challenge will be taken by your engineers. Thanks again for this talk, Arif. It was really nice to see you today, and hopefully we will see you again either in person or on the upcoming Monty Art.
Absolutely. Real pleasure. Thank you for having me. Appreciate it a lot. And yeah, have a good day.
Have a good day. Thanks.
Thanks. Bye-bye.